Let's start with Maggie in Kingswood. Maggie says, a friend of mine thinks this is all a myth, so isn't having the injections or jabs or wearing a mask. I've had all my jabs, as have all my friends. But it is safe to mix with her and for her to come into our house or vice versa. Barrett.
Well, we will always get people who will not see the evidence, even though it's there for us all to see. That's fair enough.
Yeah.
So Maggie remains at risk of infection as she is not immunized. The decision that other people take is up to them, whether they say, well, you're not immunized, therefore we don't want to fraternize with you or not. That's starting to become complicated now.
Yes.
So my view is you make your decisions, but if I were you, it is better to be interacting with people who are immunized, because that way we know that they are not transmitting infections. On the other hand, you could also look at it like this and say, well, I am fully immunized. The person at risk is Maggie. That's up to Maggie how she wishes to conduct her life. So you can look at it both ways. Um, Ideally, you want to be fraternizing in a circle of people who are also immunized. But if that is not possible, it is up to the unimmunized person to make their decisions as to which way they wish to go.
Let's still on the subject of immunisation with something that's quite contentious, because, of course, compulsory immunisation is not the way we've gone down. The rate of people taking up the vaccine has, I think, exceeded everyone's expectations. Everyone was hoping for around about 70%. In some cohorts, it's over 95%. But there are sort of areas where you would expect people to be vaccinated. Those who work in care homes and those who work in hospitals, doctors, nurses, porters, carers of people in care homes. What's your view on somewhat insisting that they are vaccinated, that it would be part of their employment?
We already do this, John, so it's nothing new. So with respect to if you are working in sensitive clinical areas, oncology ward, special care baby unit, etc., we expect and we warrant that our care staff are immunized against all the infectious diseases and make sure that they remain safe to protect our very vulnerable patients. So taking that forward, I see it as almost your duty at work to be protected so that you don't infect your vulnerable person that you're looking after. Um,
Because
so
it is a condition, isn't it, in the NHS? I mean,
it
hepatitis
is.
B is
It
an
is.
example, is that you have to be vaccinated against that because that's for your protection.
Yes, well, it's you have to be vaccinated for A, your protection, but B, so that you don't bring in, for example, your chicken pox to a very sensitive place
Yeah.
and cause havoc as a result. So, whilst we have not gone down the coercion route, I can see that, if I were running say a nursing home, for example, and I was recruiting staff, as part of my recruitment process, I would make it quite clear. The expectation is that my care staff will be fully immunized, full stop.
Mo in Clifton asks, is it safe to have the vaccine whilst pregnant or breastfeeding? What evidence is there to say that it is? Or for that matter,
Yeah,
I suppose that it isn't.
yeah, good question, and I'm very happy to answer it because the Royal College of Obstetricians and Gynecologists have clearly articulated that on balance, it is better to be immunized. So if you are pregnant or breastfeeding, it's okay, it's perfectly okay to be immunized. And on balance, it is better to be immunized than not.
There you go, Mo. Thank you very much indeed. This is an anonymous question here, and they ask, I would like to ask about research being carried out regarding the increased instances of stillbirth and COVID. I'm asking on behalf of a family member.
Okay, so we need to be very careful about assigning cause and effect. So at the moment, we do not know that there is a cause and effect, meaning the COVID caused the miscarriage. Having said that, we are well aware empirically in science that when somebody has a insult, i.e. they're pregnant, but they have an insult, they become very ill, or they get a very infectious disease, or some sort of an insult, that one of the outcomes can be and is a miscarriage. So we know that. So it wouldn't surprise me that if somebody was in their pregnancy and they got that insult, meaning COVID disease, they may, I'm not saying in all cases, not at all, but they may in some small minor cases, one of the consequences can be a miscarriage. That happens with all infections and all insults. So it wouldn't surprise me. And I'm not aware of specific research, but I would like to feel that people are looking into, is there a greater prevalence of miscarriages whilst if you have a COVID disease and you're pregnant?
I suppose it's like all of these things, isn't it, Barrett? That the one factor that we don't actually have is time. We haven't had a sufficient length of time to see whether all of these things are directly related. I mean, the blood clot and the Oxford AstraZeneca vaccine being a prime example, just because there have been instances of this very rare blood clot, we don't actually know that is directly related to the vaccine. It could be that people have had blood clots.
Yes, although that was my line initially.
Yeah. Okay.
But
is there more evidence to suggest that there is now?
Yes. So okay. Now I would categorize it as follows: that a link has been established between AstraZeneca Oxford vaccine and blood clots. Having said that, it is a idiosyncratic reaction, meaning it is not predictable, but it is very rare, very unusual, and not predictable. Some people seem to mount an unusual, unexpected reaction following the vaccination and go on to develop blood clots. Fact. Having said that, it is very rare. So the chances are greater than 1 in a million. There are chances of developing clots from other places, like smoking, like long-haul flights and travel, like the oral contraceptive pill, etc. So on balance, what would you do? I would say, well, we are also identified that in the younger age group, this idiosyncratic reaction appears to be more so. So in the UK, where we've got the privileges of choosing which vaccine, we've decided that under 40-year-olds will be given Pfizer, Moderna type vaccines, and the older age group given the AstraZeneca or the Pfizer vaccine. So that's the mitigating precautions we've already taken.
And that's, I think the line I've heard upon that is the balance of risk for those under 40 for Moderna and the Pfizer vaccine is tips in their favor.
Correct. Yes. In other words, we haven't found this link of a idiosyncratic reaction resulting in clots with the Pfizer Moderna vaccine at this point in time.
I'm going to put you on the spot. I wouldn't know whether you know the answer to this or not, but what is the incidence of clotting from taking the contraceptive pill? We know it's 1 in a million for the Oxford AstraZeneca vaccine, just from a context point of view.
Yeah. So I think in terms of quantifying it, it's common, and it would be around 1 in 80,000 or thereabouts. You see, so okay. with the OCP, it's much more OCP. I shouldn't use that expression.
Oral contraceptive pill.
Yeah. With the oral contraceptive pill, the incidence is much greater compared to the vaccine.
So that puts it into context, doesn't it? So 1 in a million to 1 in 80,000 gives you a really good view as to, all right, there's a possibility, but you could win the lottery. Kim, let's go to Kim in Bradley Stoke. Got a lot of questions to get through. Kim, your question, please.
Good morning. I've had 2 the AstraZeneca jabs. I was told the second jab is actually stronger because the efficacy is not quite as good, and that there will actually be a third one to bring it up to the others. Is that correct?
Which jab have you had, Kim?
AstraZeneca.
Okay, Kim, let me explain it to you in a different way. So the first vaccine that we give you is what we call a priming dose.
Yeah.
And then the second vaccine that we give you is what we call a boosting dose. Both the vaccines, the first one and the second one, are exactly the same. It is not a case of the second vaccine has got more of the material in it or anything like that. It's exactly the same vaccine. It's just that
Yeah.
the first one primes you, meaning it introduces the antigen to your body, and your body is told this boy is a bad boy, prepare some antibodies against it. And then the second vaccine boosts that introduction. In other words, it says, look, here I am again, mount some more immune memory against this thing that we don't want in our body. And then to answer your question about the third vaccine, yes, that is very much on the cards, and we expect to give a booster, a third booster, in other words, a third vaccine, second booster, to keep your immunity boosted, because we don't know how long the immunity lasts. And one way to keep on having your immunity lasting is to keep on boosting it. So we're going to boost it in the autumn, and also at the autumn time, it may be an opportunity to reformulate the vaccines in case there are variants which are bypassing the original vaccine that we gave to you.
Right,
there you go,
thank
Kim.
you.
There you go, Kim.
Much.
A couple of things I wanted to get through, if I may, Barrett, before I let you go, because I know you want to talk about specifically about India, which is incredibly important because it gets to the heart of nobody's safe until everybody's safe. But I just want to explore very briefly with you local autonomy, just something you were talking about a little bit earlier. Because we know that the tier system actually fundamentally, when we look back at it, didn't really work, because the Kent variant clearly hadn't read the criteria of the tier system back in December and January of last year. What specific local controls do you think public health need in Bristol, in Bath, in South Gloss, or indeed North Somerset?
I think what we need is a integrated local team which works together, and in many ways they do. Unfortunately, they are not allowed to take local decisions in a big way. So in other words, it would have to be Matt Hancock saying, yes, Southwest, you are allowed to go into restrictions and so on. And we need that dynamic actions so that you act promptly, you act fast, you act as fast as the results are coming in. So we need, going forward, that timely action as a result of what we are seeing at the ground level. I hope it will happen, and I'm sure it will be enabled, because lessons have been learned that you work better if you allow the local team to lead.
Local flexibility, I suppose, isn't it? And
yes.
The ability to look at the detail in a granular way and go, bang, we need to do something. Let's talk about something which, of course, isn't here but is in India. And you come from India, you have family there. We see the pictures. They are heartbreaking. But actually, it's more than that, because, of course, what's there, as we now have seen in Bolton and Bradford, comes here fairly quickly. What can we do to help India?
It's very difficult. It's a tidal wave and so difficult. So people like myself have got together with other clinicians, and we are working very hard at raising funds. We're more important than funds, I feel, is passing that simple message of don't call your doctor unless you need to, and don't do polypharmacy unless you need to. So those are health promotion, health protection messages that we are dishing out via webinars, etc. And then, of course, it is to impress upon authorities about setting up field hospitals and treatment centers in a big way, rather than at the moment people are at the mercy of going to private hospitals and paying a lot of money. India will do better to have lots of field hospitals, economies of scale.
One last question, and I got a comment for you as well, but one last question as we hurtle towards the 11 o'clock news. One thing we should be doing above all else right now, minded of where we are locally in this pandemic, what should we be doing?
Don't drop our guard. We've endured a difficult 12, 14 months, and our immunization program has been very successful. So don't drop your guard, and we need to maintain our border controls. But remember, a variant like it did from Kent can arise in the UK as well. So suppress infections locally, nationally, internationally, and don't drop your guard. Simple, don't drop your guard.
And Sheila in Clifton says, I don't have a question for Barrett, but I would just like to say thank you to him. Throughout the pandemic, he has been a comforting voice of reason. He has explained things clearly and honestly, and I'm sure I'm not alone in very, very grateful to him. A message from Sheila, which I know is echoed by many listeners to this programme. Barrett, well, no, sincerely thank you. We will speak again in a few weeks because we've covered a lot of ground, but we are at a very difficult, sensitive time now, both locally, nationally and internationally. But for now, Dr. Barrett Pankania, once again, thank you for being on the programme.
Thank you. Good morning.